Well, welcome everybody to the February 22nd Wyoming Telehealth Network webinar. So these are a series of monthly webinars where we talk and bring to you best practices in telehealth, either bringing in national speakers or local experts who are doing a phenomenal job in utilizing video conferencing, telehealth services to improve care for Wyoming residents. So today we're going to have a wonderful conversation that's a collaboration between the Telehealth Network and Cheyenne Regional Medical Center, talking about their work in telebehavioral health. Just to orient you to a couple of things on Zoom for the session today at the bottom, and I'll actually let Kyle orient people.
Yeah. So what we just wanted to let you guys know is that you, of the participant features and then of the chat feature and the raise your hand feature. So if you move your mouse around the Zoom screen, like kind of where our faces are at, that'll bring up a secondary menu. And then on that menu, starting from left to right, there's a microphone so you can mute and unmute yourself, and then the video icon, same sort of thing, you can mute and unmute it. And then if you need to change your name or rename yourself, you just click on the participants button, and then find your name, and then a blue button will pop up that says rename. And then finally, that's also a spot where you can raise your hand, and that'll kind of cue us that there's a question, and we'll probably save all the questions till the end. And then last but not least is the chat feature, sorry. It's the little chat bubble icon. If you click on that, you can send messages to everybody. In that, I've posted a couple of captioning links. We have live captioning available. Is that everything?
Yeah, that sounds good. So yeah, we recommend people, if you would go ahead and try that live captioning link. We use it here in the room, but definitely it helps with understanding and accessibility. I am going to take a moment because we do have a couple of sites that have joined on the phone, and that helps our attendance and credit person, Sarah. Give everybody a wave, Sarah. Keep track of who's attending this webinar for the purposes of reporting and those additional pieces. But we're going to go ahead and open up the phone lines. We have somebody who's called in from 265-4343.
Hi, this is Ashley from Wyoming Neurologic Associates.
Oh, wonderful. Okay, Ashley, we're going to go ahead and rename your screen. We'll keep you muted just for the purpose of when Kevin and his team is presenting, but definitely unmute your line so that you can jump in and share your perspective as well. So we'll rename your screen. We've got a couple of other phone lines here, 272-1132.
Yeah, this is Holly from Ascension's Health Network.
Perfect. Thanks for joining us, Holly. We'll go ahead and go to 751-1636.
This is Deb Anderson with Mountain Pacific and Health Technology Services.
Perfect. Great to hear your voice, Deb. Thanks for joining us. And then we have 823-6886.
Hi, this is Kristen Siplin. I'm with Optum Y Health.
Perfect. Thank you so much, Kristen. And I think everybody else has done a pretty good job of renaming their screen. But just as a reminder, go down to participants, click on your site name, and actually rename it to represent your first and last name and the organization you represent. So with that being said, we will go ahead and turn over the time to Kevin Smith and learning about the wonderful work they're doing around telebehavioral health. So thank you so much, Kevin, for joining, and the time's yours.
Thank you. We appreciate the opportunity to join as a presenter here for Wyoming Telehealth Network, and we also enjoy the partnership we have with the University of Wyoming and the Wyoming Department of Health in furthering the Wyoming Telehealth Network and the adoption of telemedicine in Wyoming. I bragged so much about everything that we're doing over in Cheyenne to the group over in Laramie all the time that they finally said, you know, maybe I ought to ask our folks to present some information on it. So today I've done that, and with me today is Sharon Pendlebury on my right here. She's the administrator over behavioral health services here at Cheyenne Regional. To her right is Heather Montrose, who is a manager of outpatient behavioral health services here for the unit. And Jennifer Zimmerman, who is the administrative coordinator, kind of keeps the schedule and the ship running, whether it's court or whether it's appointments and all kinds of things. So we're prepared today to give you some background about our our behavioral health unit and some of our experiences. And Canyon, if you want to go ahead and just pull the slide off of the screen, maybe we can see each other better. And there isn't, I've got an outline there. We'll make that available to folks later, but that's better. Thank you. So on my right is Sharon. I'll let her begin to give us a little background about Cheyenne Regional's Behavioral Health Unit. And she's our champion. I was saying before we got started here, if I had every service line had a champion like Sharon here, we'd be doing a lot more telemedicine in Wyoming. So
thank you.
I'll turn it over to you.
Thank you.
Yes.
Good afternoon, everybody. It's nice to meet you. As Kevin said, I'm the administrator for behavioral health at Cheyenne Regional. We have 3 departments: inpatient, outpatient, and our crisis team in the emergency room, our psychiatric assessment and referral team. Briefly, our inpatient unit is an adult inpatient unit, locked, 16 beds, 2-bedded psychiatric intensive care unit. Our outpatient services are broad and deep, and Heather takes really good care of them. One of our outpatient services is our telehealth outreach, and it's a vital part of our provision of care, both within our own community and on a much wider basis. I think it's extremely important. We serve people by telehealth who otherwise would struggle to engage with our services and therefore wouldn't benefit from them. Access is everything, you know, the triple aim: right patient, right place, right cost, and we're able to do that using telehealth. And I think our whole service line are strong advocates for that. We have the advantage in that we have a telehealth team on site who are excellent and extremely supportive. So we don't have to worry about connectivity. We don't have to worry about our patients being able to be comfortable with the process, because we have a team that can reach out to them and work with them on that. We don't have to worry about our providers being comfortable, because again, they get a great deal of support from Kevin and Randy until they really get into the gig. So we're lucky, we're fortunate, but we use telehealth a lot. And if we didn't use it, there are definitely populations within our own community and within the state that would not be being served with psychiatry as they are now. And that's everything, really. That's why we're here. So we also have our psychiatric assessment and referral team in the emergency room. We use telehealth in the emergency room for programming. We have a significant number of boarded patients awaiting beds for psychiatry. So we, under Joint Commission EP 6 and 9, we manage and maintain those patients. So after 24 hours, psychiatry goes over and helps the ED attending, who remains a physician, to manage psychotropic medications. And after 24 hours boarding, our patients in the ED have the ability to attend our groups, if it's appropriate, on the inpatient unit by telehealth. So that really ensures that at least they're making a start while they're waiting for a bed. In terms of inpatient, outpatient, and our ED, we also have a lot of collaboration with the legal system. We have court in the emergency room. We have court on our medical floors for patients who are waiting for beds. And of course, we have court on our inpatient unit 3 times a week. The court uses telehealth in order to increase their ability to see the number of patients we have in the community between us, the jail, and the VA. And Jen will talk to you a little bit more about that later. The ability to use telehealth has made it possible to serve those patients for their legal needs and their right to have legal advocacy. Without it, we would really be struggling in this community to do that. The time to move people from one location to another would take up the entire time we have court commissioners and our attorneys for. So we use telehealth a lot. I would like to use it more. We use it within our service line. We use I mean, it's the 21st century. We use Polycom. We offer our team members, our employees, Polycom. If they can't, they can get that set up on their computer for Kevin and Randy. If they can't get into a meeting, they're driving an hour to an hour meeting and driving an hour back, they can attend that meeting by Polycom. They don't need to be driving an hour either way. That's fine. We do a lot with telehealth. And I expect as we go forward, we'll do more.
Nice. I hope so.
Me too. Access is everything. Patients can't get better if they don't have access to treatment.
Great.
Great.
Do you want to talk a little bit, Heather?
Yes, so I'm going to talk about telehealth services from an outpatient perspective. So what we do on our outpatient side to provide telehealth services across the state. And so again, we've been doing telehealth now for
Nearly 5 years.
nearly 5 years.
Yeah.
Wow.
A long time.
So a long time. So we've learned a lot of lessons throughout this process, and we're going to talk about kind of the lessons learned because there are many of them. And I think it's really helpful to share that for anyone who's trying to get established or up and running in telehealth. But to kind of walk you through how we design our telehealth service, I'm going to kind of talk first how we get a telehealth site. And so currently we have acquired our sites by people just reaching out to us. People calling us and saying, listen, we are in, I'm trying to think of Thane, Wyoming, and we really have no psychiatrists that can provide services. And so they've actually reached out to us, and we have a conversation about how we might be able to be helpful. And then if it feels like it's going to be a good fit and a good partnership, then we'll go ahead and we will establish an MOU. So a memorandum of understanding is what we establish with that site. So that's really the first step in the process. The second step, once we have a site established, is to really talk about how the workflow is going to work for that particular site, because every site is going to be a little bit different in that workflow based on what resources that they have available. And so we're going to have that conversation, but one thing that we do for every site is that we have a new patient packet. So any patient that is going to be coming through behavioral health is going to need to complete this new patient packet or have someone else complete that with them. And so I'm going to tell you a little bit about our new patient packet. They're going to receive a welcome letter, and that's really going to welcome them into services because we're going to treat them as though they are here in our clinic. So essentially, every visit is as if they came into our clinic and they're just seeing our provider within our clinic. So all of our billing, storing of the documentation is going to be in our electronic medical record system. We use Epic here at Cheyenne Regional Medical Center. All that's going to happen as though it was any other patient coming in. The challenge is going to be that we need some information, like we need to have vitals before they see the provider, and we need to have a nurse screening before they see the provider. So in that new patient packet, we're going to have them sign a consent for services like any other patient coming in here. We have a second consent that's going to specifically target telehealth services. So they will have two consents. We're going to have a release of information so that they are giving us the ability to communicate with that site for scheduling purposes. That's pretty much the limit of the release of information, unless the site is maybe a group home site and we need to share maybe more information with that site. We're going to make sure that if there's any guardianship paperwork that we have that, and then of course we're going to do the same thing with any other patient. We're going to get a photo ID, we're going to get insurance information, and we're going to make sure that we can verify that insurance and that the insurance is going to cover the telehealth service. Then the nurse screening, we're going to do that basic history, all that good information on the nurse piece. Our nurses take that information and they're going to put that into our electronic medical record system. So we do need to use paper. We're trying to move away from paper as much as possible, but we haven't found another way around that unless the nurse is able to connect with that individual over the phone, and in which case our nurse is able to do that nurse screening over the phone. One of the challenges, and we'll talk more about challenges, has been the vitals. We've gotten to a point with our sites where we've been able to streamline getting vitals before the patient is seen, because that's really important for the completion of our electronic medical record. So we do ask that the patient is able to acquire those vitals and put those into so we can put those into the system. Once we have all that information, then we can go ahead and look at scheduling. So the front end process of establishing a new patient in telehealth, there is a little labor intensive. However, once that's completed, the patient is really good to go, except for yearly consents that need to be updated. The other thing that we use, and we use this for every patient in our clinic, is we use the PHQ-9 depression screening. And this is really our quality indicator. So we are making sure that we're kind of tracking the progress at admission and discharge. And like I said, we do that for every patient coming into our clinic. With telehealth, though, safety is very, we want to make sure that we are ensuring that the patient is safe. We will have our MA take that new patient packet, screen the packet, and if the PHQ-9 score is alarming, so it's high, or the patient is indicating they may be suicidal, we're going to have an RN reach out to them right away. We don't want any packet sitting for any length of time without being reviewed in case a patient is potentially at risk. So that's how we establish a new patient into the clinic. We have various types of clinics. Currently we have 8 sites, but within those sites, we may have other community partners using that site. It may just be a community member that's using that established site, or it may be another group. So for example, we have a site called Pioneer Counseling, that's in Evanston, but we have 3 other groups that are also utilizing the technology or utilizing Pioneer for telemedicine. So all of our sites are set up a little bit different. We have sites that are for intellectually disabled patients. We have nursing home sites. We have community mental health sites. I think that's about it. And we have doctor's offices as well. So we have kind of the array of sites, and each site we've kind of learned something new from each site, which has really been great in our ability to grow and to reach out to patients across the state. We are able to see patients across the age spectrum, so we are able to see children and adolescents. And so for that, it's really important that we have a nice big screen so that we can see the child, because oftentimes the child is not going to be sitting right in front of the computer screen. They're going to want to be moving around. And so we need to make sure that our technology is able to accommodate that. So we have very large screens in all of our provider offices so that they can actually feel like they're able to interact a little bit more with that child and really see what that child is doing so that they can prescribe appropriately. So we are able to see kids, adolescents, and then of course seniors, geriatric population in the nursing home. So some of our patients are in memory care units, and we are able to serve those patients as well. Obviously, those patients, it's really hard to get them out of the building, and so it's really nice if we can get in there and have a computer screen that a nurse can take around and kind of put before the patient in the memory care unit so that we can prescribe medications for that individual. We are also able to do teletherapy. We haven't done a whole lot of therapy by telehealth, but we do have the capacity to do that. And with that, we just make sure that we have certain kind of safety marks in place. For example, we're always going to get the patient's phone number and current location. So we want to make sure we have a good phone number that if there's any risk that we're able to call that number. We're going to do a risk assessment. So if a patient is suicidal, we're going to be calling that site right away, especially if we need to be doing a welfare check. So we really want to make sure that if there is a level of risk that we're addressing that immediately and able to keep that patient safe and not allow them to leave that site until we're able to have someone check on them and make sure they're okay. Because some patients are going to have a nurse or a case manager in with them, and some individuals are not. They might just be a community member that's simply coming in and using the technology that site offers. So all of our patients are aware that when they come into services, that if there is a need to conduct a welfare check, we will conduct a welfare check wherever they are in the state. So that's really important to us so we can ensure their safety. I'm trying to think of what else I might be missing. We do, again, we haven't run into it a whole lot, but there have been times when insurance companies do not want to cover telehealth. We drop what's called a GT modifier on the code. So we're billing again as though they were in the clinic with the exception of that GT modifier, which indicates that it is a telehealth service. So most insurance carriers will cover that, but we have had a few that would not. And so we try and catch that as quickly as possible for that individual. We have also started to work to expand our telehealth capacity to model what we call individualized telehealth service. And this is new for us, but this is really to provide patients the opportunity to be seen at any location of their choice on their own equipment. So this would allow someone to be seen at work if they want to take a lunch hour and they need to have a session, and they can work with Kevin and Randy, our team, to get Polycom installed onto their personal equipment, and they can have an individual session wherever they want to have that session. One of the challenges with that launch is that insurance carriers at this time in Wyoming don't cover that. It has to be established at a site. So we have had a little bit of difficulty getting referrals for that, but we are very excited to continue down that because we really feel that technology and reaching patients across the state when it's convenient for them is really the wave of the future. So we're going to continue to advocate for that program as well.
I should interject a little bit on that. We actually work very closely with the Veterans Administration on a very successful program that they can offer through the VA, and they have very significant numbers of users that take advantage of that method of being able to not have to come into a location and be able to do it either from home. Now with the VA, of course, they have the benefit of reimbursements not an issue, and state lines aren't an issue. But learning from their experience, our protocols were designed so that when we do have the opportunity to do a what I would call a direct-to-consumer type face-to-face meeting, we have a good protocol in place.
Yes.
I also think that we'd have a little bit, if we marketed this option a little more, we might have a little more traction in that area. I do think there are people, and we know in other states, there are people that are willing to pay, $100, $150 for a visit simply so that they can have the confidentiality and the privacy of doing it from their own location. So I think we'll see that grow. But I wanted to let you know that even though we don't have a lot of experience with that yet, we do have a good protocol and guidelines in place. So.
And again, it's about access. It's, yes, I do need to see the psychiatrist. I do need to meet with my therapist. I live 3 hours away from the nearest therapist, and I work, and there is no way I can see a therapist once a week for 12 weeks when it's a 6-hour round trip. Just not going to happen. And so the idea is that we develop functionality for people so they can access care when they need it. And that's just one other option for that. And there are many people in this state who find themselves in that position. And so hopefully it'll take off.
Yes.
Yeah, so I will go ahead and turn it over to Jen, now that we've kind of talked about how we function with telehealth, to talk more about the court process and using telehealth. Yeah.
And let me just interject one more time. Before, I don't know if we said it in the beginning, but please, we're saving we're saving our questions towards the end so that we have a chance to do a very fluid question and answer section. So please know that we're gonna, if you have questions you're waiting on, we're gonna leave plenty of time to address those. So go ahead, Jen. Thanks.
Okay.
Well, and we've been doing telehealth for our court process for a little over a year now. And in that process, we actually have been able to utilize our time more appropriately for court instead of having time for people being transported from one place to another, which became quite time intensive for our independent examiner as well as the attorneys and the judges or court commissioners that were used for that process. So we are able to facilitate 3 different locations of having court, 2 locations normally simultaneously, because we'll have one individual at one location that's part of the court process, while 2 people and the, I'm sorry, 3 people, 3 locations going simultaneously. There's one in the court, district court judge's office. They'll be having court there where people are, the judge and the a county attorney will be in that location. We'll have the patient and their attorney in another location and an independent examiner in a 3rd location, all of which is completely confidential and is HIPAA compliant. So it has allowed for the process of travel time for not only getting to the appointments, but also for people being able to stay close to their location and be able to make other meetings extremely viable. And we have found that our patients find that it is better because we don't have to take them out with certain types of illnesses, that it would be more confusing for them to move them once again, to have the process there where they're comfortable and where they know that the staff that are there to help them and feel safer in the situation. We have been to, it's just been tremendous, I have to say. We have, the idea to start with was a little concerning for our patients, but we have learned through the process as we are explaining the court process, which is scary to begin with for them, but explaining them how it's going to work on the TV and how they would be able to interact, that the patients are actually more comfortable than they were when everybody was in the courtroom and there were a lot more eyes they felt on them. So they are actually more comfortable in being able to talk about their circumstances than they were when they were all sitting in one room together. So it has been helpful in that aspect.
That's very.
As the coordinator for Cheyenne Regional's telehealth program, the ability for us to be able to do the court hearing is a good example of the kind of collaboration it took. The need was identified because the county, Laramie County, we've got a higher volume, we have a pretty good volume of patients that are needing detention hearings, and the budgets were getting thinner. And by working with the county attorney and then getting them to consent to doing it this way, it allowed us, one, not to transport patients in shackles, which was the old-fashioned way of doing it, down to the courtroom.
We don't do that.
So they are able to stay in either in their treatment room in the east facility here or over in the clinical rooms over in the west facility. We also, because the courthouse has their own IT department, we had to coordinate with the IT folks in the courthouse, and then the Supreme Court for Wyoming actually controls the video equipment within the courtrooms, and so it took coordination with them. So the ability to get all those pieces together was actually in 2 weeks. We did it in 2 weeks. Yeah, a year ago December, and it's still working very well. It's not unusual for us to have upwards of 9 or 10 court hearings scheduled on every one of those 3 days, and sometimes many more. It also allows us, by bringing those multiple points together, to have a much more efficient way to be able to get those patients their legal hearings. They have time to spend with their legal appointed attorney, and whether they're all together here or whether they're scattered around, we can bring them all together to the court and conduct a very effective hearing. So it's working very well for us with the volume that we have, and makes it much better for the patient.
It does. So I think that's
Lessons learned.
the best bit.
Yeah. So some takeaways that we would like to share, because it might be helpful for anyone who's wanting to establish telehealth. We'll talk about now. One thing that we do every year is once a year we do go on a road trip and we actually visit all of our sites in person. And I think that's really helpful because we spend a lot of time talking to other sites, but to really know what they're working with or the space that they use, we really have no idea. So it's really helpful to go visit the sites.
Road trip.
We can see the room that they use for telehealth. We can talk about the process and really have that kind of face-to-face connection with which I think is really helpful in the partnership. So we did our last trip in the fall, so September, myself and our front office supervisor went and did hit up all the clinics. And so I'm going to share with you what we've learned and then just over time what we've learned. So one thing that we have found to be tremendously helpful is to have a designated site person that we are consistently working with. When we tend to work with multiple people at a site, it gets to be very chaotic and very confusing. And so we really want to make sure that we are forming that partnership with one particular person. Maybe have a backup, but that we have a person that we can call at any point if there's technology problems or patients needing appointments, just anything that happens, we want to have that point person in place. With that, we want to make sure that we're having routine meetings with the site. And so while my front desk team may be talking to the sites every day, it's nice to have a formal meeting once a quarter or whatever's necessary to at least check in with the site administrator on their end to make sure that everything's working well. What improvements can we make? Where are there gaps in trying to make that flow as easy as possible? So that's been really beneficial to do that. One challenge that the sites have had is that with telehealth, there is a originating fee that they can be charging individuals coming in and using their technology. And so the site actually can charge $25 for that individual to use their technology. Now, most sites have not been able to successfully pull this off and to bill the patient. And so CMS right now is conducting a nationwide audit really to improve this and to make this easier because it has not been successful for the sites.
We send out our lovely CMS packet that tells the originating site how to
do
apply,
it,
and it doesn't happen. And so the Office of the Inspector General is contacting a number of sites across the nation, including ours, to see what the experience has been and to review those challenges, and hopefully they'll improve that because it is an opportunity for the originating site to be able to cover some of their costs in terms of having somebody there to show the patient into the room, having that direct person that we talk to. So some of that reimbursement really would be helped by the fee, but at the moment it's really difficult to charge it. Much more difficult than the receiving site, us, to charge.
Right.
And I know from my counterparts around the country, you know, we'd all like to see that originating site fee more than $25 because I think it would be an incentive for more people to do it. But right now that's based on what CMS pays.
And most people aren't getting it.
Right. So, but they are eligible to do that for helping us room patients on the originating sites.
Right, because like we talked about, there is a labor cost to have our service on their end. I mean, they do need to have someone to turn on the computer and make sure it's working, and maybe take vitals, or be available if there's something that happens in that appointment where there's some concern of risk. I mean, so they do need to have someone to help support the process. One of the other things that's popped up over time is with technology. As we love it, sometimes there are barriers in technology, and although we have Kevin and Randy that support us very greatly, not all sites have had a lot of support, and so that can be challenging if there are any hiccups that are happening that we need to try and troubleshoot.
Firewalls.
Right, and we have lost a site because their firewall would not allow, our Polycom.
Most of the time it's related to firewall not being properly configured to allow video conferencing through. And usually if they have an IT person that we can work with on the other end, we can usually walk them through getting through that. But some sites just don't want to go through the effort or don't want to don't believe that we can safely penetrate through the firewall with common video and not make them vulnerable. Doesn't happen too often.
I think it's only happened once.
More times what happens is the far end site has an upgrade done on their firewall and they don't know about it, and they try to connect on a routine call that happens all the time, and something happens that they can't, and it only takes a few minutes for us to work with an IT person on the other end to get it straightened around, because most of the problems are pretty common. So even though those occur, they're also usually easy to resolve.
Yeah.
So.
Mm-hmm. The other challenge with the technology that we found being in a rural state is that the bandwidth has not always been strong enough to support a nice clean screen for telehealth. And so that was actually something that was really unanticipated, that we found that some of our sites, just the quality of the video is not great because the bandwidth is not great in that area, and we really can't do much to change that.
There are some locations we know. The Torrington Valley right now is kind of infamous because of problems of just where the state LATAs reside with phone and cable, but it's improving, and the governor's initiative on the broadband initiative has helped. And we've done some successful work with wireless telephone connections through, if we can get a 4G connection with a wireless phone, like in Farson, Wyoming, for example, we can oftentimes, we work with them, not so much with behavioral health, but with other clinical modalities where with a good cellular connection into a tower, we can actually do good video with some peripherals attached to that as well. So as technology has gotten better, so has access.
Yeah. And then I think one of the other challenges can be just collection of co-payments and things to that nature, because we're working with someone off-site, and so we do our best to have patients mail that in, give us their credit card number over the phone if there's a payment due. But sometimes that is a challenge when there's distance, and if they mail us something, it can get lost in translation. And so sometimes that can be a challenge, as well as getting that collection, although it can be a challenge anyway. But that is, just another hurdle when you have space and you don't have that patient walking in and seeing you. Otherwise, those are, I don't know, Jen, if you have any other
one of the things
on...
when we first started out doing telehealth that we had as a hurdle that we've kind of overcome is people being afraid of the technology to actually use it. And so once you found somebody that was there to actually do it a few times, they became more comfortable. But the first couple of times they were a little standoffish, and we'd be on the phone a lot with Kevin and Randy working through just how to log in. And then once they felt comfortable, we were off and running most times.
I think that's a good point. I think you can anticipate that people are going to need a fairly intense level of support for the first 2 or 3 visits, and not worry about that or panic about it, because they just will. And then after a little while, it just becomes fine.
Yeah.
Does that leave us some time for questions now?
Yeah, so we have about 20 minutes. And it's wonderful work that you're doing, and I think there's a lot. We have a couple questions here in the room, but we'd love to go out to the community. Recommend that people go ahead and turn their videos on. If you have a question, go ahead, unmute your lines or raise your hand, and we'll unmute you. But for sharing and success stories, this is great.
Yeah, it's been good, really good.
Very good. Okay, so as people are kind of either typing in the chat or thinking about their question, one of our questions here in the room to Kevin and your team is, what's your capacity? So it talks about, you guys talked, I think that you said 8 sites throughout the state that are connecting in on a regular basis.
Yeah, we do. It depends, our capacity per site.
Or your capacity for sites. Like could you accept 7 more sites?
No.
The demand is always the demand is always greater.
No, it's all, yes, it is.
And while Sharon's formulating an answer, I can tell you that as we said in the beginning, the sites we're supporting now have been sites that are in need of psychiatric Services.
They came to us.
They came to us.
Right.
We have not really marketed this as
Mm-mm.
as an enterprise. We haven't tried to make it a profit center. Sharon's attitude, speaking for her, I would say, is that we're here to help. Her folks are here to support. We've been asked on occasion to try to provide. We do have a couple, or at least one large group home in here that they contract with specifically to provide services, but we've had to turn away some people that had more need than we knew we could support.
Correct.
Based on taking care of the inpatient unit, the ED, and the sites already. So they try to be flexible, and they try to make sure that it's more than 1 or 2 patients to make it worthwhile for everybody's effort to get set up. But it's also, like when you said, can we do 7 more sites of 5 or 6 patients at each site? Probably would be a big stretch for your staff.
We have, in our outpatient clinic, we have 4 psychiatrists, we have 7 therapists, and we have 3 psychiatric nurses and 2 psychiatric MAs, and obviously our front desk administrative team. And we're the busiest clinic in our health system. We see 80 to 100 patients a day on site. And so, and then we outreach to nursing homes. We put psychiatry into our face-to-face psychiatry into our nursing homes. Mm-hmm. We have our Be Well project. So we put therapy and consulting psychiatry into each of our patient-centered medical homes in our health system, and a couple of other specialist clinics. We have mental health IOP, CDIOP, Suboxone program, ECT in and outpatient. So we're really, really busy. However, if people need us, we'll really try and help.
Right.
We had a phone call from a community mental health center about a year ago now, who had lost their psychiatrist and didn't have a replacement and didn't have many options, who said, we're carrying 80 to 100, 80 patients at that time, who really need to see psychiatry. Can you accommodate us? And I'm not quite sure how Heather did it.
But we have.
She persuaded our psychiatrist, but we did. Because otherwise that community wouldn't have psychiatric support, and that's just not on. So no, we probably couldn't take another 7 sites, but if people need help, we'll try our very best.
Yeah, we found that it's most, in terms of lessons learned, it's easiest if we can, what we've really tried to move all of our sites to is a block that's reserved for them. And so kind of depending on the need of that site, it might be every week you have 4 hours of a psychiatrist. And so you can schedule within that block, or 2 hours a month, whatever, kind of based on the volume of the site. So we have tried to move everyone into those blocks so we can better, it's just easier for coordination. And if there are any technical glitches that are happening, we have a block of time to really try and sort that out and get patients seen, versus what we used to do is just kind of schedule them in the provider's schedule as though they were just another patient coming into the clinic. Well, if that's a 30-minute appointment and there's some glitch and you spend 15 minutes trying to figure that glitch out, you don't have really a lot of time to see that patient before the next patient is going to be seen. So we try and match the block with the volume at each site. So that really helps us to kind of monitor our usage and really determine, can we take on another site? And that really is one of our first questions is, what is your volume? What are you looking at? Do you need, 2 hours a month? We could probably accommodate that. Do you need a full psychiatrist 1 day a week? Probably not right now, because we're trying to have that delicate balance of serving our patients here in this community, which we know psychiatry across the state is very limited. And so we need to make sure that we are serving Cheyenne as well.
Yeah, that's true. And I think the blocks have really helped, because then either Kevin or Randy is always a vet that we tell them when.
They know when
the blocks are. So they're always on hand. So if we do run into a glitch, it can be fixed within a few minutes, rather than, oh, we need to call Randy. I wonder where Randy is. Or maybe Randy's in a meeting or helping somebody else. And so we kind of reserve Kevin and Randy for our blocks. And that has really helped, because that if there is a small glitch or somebody's forgotten how to do something, then it's sorted out in the moment and we can get on with that appointment.
Right.
And like right now, we have actually 3 sessions of telehealth going on right now simultaneously.
Yeah.
So if we catch with one that we catch, then we can normally catch another issue
Yes.
before we get started.
Right.
Yeah. So yes,
I have
the
a
short
question.
answer is we'll take new patients. But we don't
Okay.
always have them.
I'm not sure who that is,
Can
but
you
go
hear
ahead.
me?
Yes.
Okay. This is Michael Murdoch from Lander. I'm a speech pathologist. And I was late getting in on this because I had a patient over in Riverton that I was seeing. So I was wondering, and just to mention, I did telehealth with the VA in Sheridan for 5 years. So I'm
It's a good program.
fairly familiar with it. But what did you explain what your referral process is? If I should get a referral for a patient, then how would I go about getting them connected with your telehealth service, with the telehealth service?
Yeah, so we have our 8 designated sites at the moment, and some of those sites are open to taking other community members or community groups. And so what we look at first is there a site that we have already established that is close to that patient, and then we would want to refer them into that site if possible. Because if we are establishing a new site, it takes about 8 weeks to get through, 8 to 12 to get through the
And we have
MOU
to have a
process.
site.
It's the
Yeah.
paperwork usually. I mean, we do have to have a site, but the legal review process is frustrating for all of these folks that want to take care of people.
Yeah. So if you had a referral, we do get phone calls where someone across the state calls us and asks, where do you have sites? Because I have
Could I
someone.
access it?
Yeah, can I access it or
patient.
have someone who needs to access it? And then we try and direct them accordingly.
So
Oh,
really
okay.
just
So
call
are
into
you-
our front desk and try and be helpful.
Yeah,
Yep.
so this is going to be recorded and available on the WyTN website, and there's also will be a handout that I'm going to update a little bit and get some better detail in with some contact information that will be
Yeah, just call the
available
front
also.
desk and we can-
And but you can always call the front desk here at Behavioral Services, and they'll try to help guide you through that process.
Absolutely.
And I'll have that number available for you.
Okay, are most of your sites the same as the 7 VA sites?
No.
Or are they different? Some of them
No.
the same?
Yeah.
I think they're mostly different.
Yeah, the VA telemedicine network is closed to just the VA under the federal requirements, and so
Right.
they, as much as we would like and they would like, right now we're not able to
Partner.
we just can't join their network, and they're not allowed to go out of their network to join us. So right now it's usually in one of the other mental health providers' offices in different locations, or physician's office or nursing home. So they're another medical originating site usually, other than VA.
So maybe what we
Oh,
can do,
okay.
Kevin, is
Thank you.
we can list the locations of our other sites on
Yeah.
one of those handouts so that you'll be able to see where
Which is
each
nearest.
site, is located.
I'll include that. I'm going to
Okay,
send you an updated bullet point canyon so that we have an updated version to put on the web.
That'd be good.
Perfect. So
Okay.
go ahead and make sure when you send us to that, Sarah will send it out to all the participants, of which we have email addresses, and also post it on the website. So there were a couple questions about sites, and just to kind of refocus this, I mean, it's definitely, we want to talk about the services that you guys deliver, but even more important, as we have sites on the line who are thinking about expanding telehealth, it's those lessons learned is a really wonderful kind of way to refocus that, right? So yes, we want to offer the services to individuals that would help, but it's helpful to hear you don't currently have the capacity. So we're also trying to give individuals lessons learned as they think about ways in which they can offer their services via telehealth in a manner as well. So,
And we're more than welcome to share whatever we have. We have our Obviously, we have our telehealth packet. We also have our protocols, our template for our MOU, the individual telehealth protocols that we built for the individual one-to-one program. And you're welcome to share any and all of those.
Great. So those may be additional things we'll post on our website and maybe even have further discussions about maybe on a separate webinar, right? How do you guys go about establishing an MOU when we get into those nitty-gritty things?
Yeah.
So there are a couple questions that we want to make sure that we go to. So one of them, we're going to open your line, David, from North Bighorn Hospital.
I've got a laptop linked to a screen, so can you hear me okay?
You're pretty quiet, so just...
We can hear you.
Okay, I'll lean over. We currently use telemedicine for a number of specialties, mostly with providers that are coming out of Billings Clinic. Of course, we're at the far northern reach of the state. But had a question specifically about interacting with the courts you mentioned. Do you do anything with providing therapy services for inmates in the jail with them in that jail location? And then I had one other question after you answer that.
We have been asked, but the volume at the moment is just too much for us. We don't have the provider resource to be able to do that. We've had several discussions over the last 4 years, 3 probably, about whether or not we're in a place to do that. I think it would be a very viable thing to do, frankly, especially for behavioral health, because you're not laying hands on your patients quite so often. And so they certainly run the court system into the jail by telehealth in the same 90 minutes that they serve us and the VA. So it works, and I think it would work very well. But do we do it? We haven't had the capacity to do it. That's a big population in Laramie County.
Okay, yeah, and of course proportionately smaller here, but again, a big need, I think. The second question is on privileges for providers. With very few exceptions, and it's just the last minute kind of consult thing, the providers that are participating in telehealth appointments with the, us as the originating site for the patient, those providers are credentialed at our facility. Now, I'm not sure if that is our policy or just a general way that it's done, but just wonder if you could comment on that.
We don't privilege our providers with the originating sites. We literally treat the patient as if they're in our clinic. And so the providers are obviously credentialed through CRMC, through our hospital system, privileged and credentialed. And the patient is essentially our patient. If we are partnering with an originating site for the purposes of support, for example, with a community mental health center where the patient is also seeing therapy, obviously we structure that so that there is partnership between the therapist, the patient, and the psychiatrist, just like we would if they were seeing a therapist in our clinic for continuation of care. But we don't, our MOU does not allow privileging with the originating site.
And David, this is Kevin. Let me just add a little to that. I know that our experience has been that it makes it's easier for us to provide services without having to go through the credentialing hurdle when it's a clinic and not a hospital. A lot of Wyoming hospitals require credentialing from hospital to hospital. And so it's easier for us sometimes to be able to not face that credentialing issue. And fortunately, we do have, the hospital in Newcastle was an obstacle for a while in being able to do the services because of the credentialing question. And they actually changed their bylaws to allow us to be able to do that without requiring the credentialing of our profession.
Yep, the only thing we had to send was basically a letter just saying that we run them through the full credentialing process. And
explaining it through med staffing.
Yep, and then we send that to them, and that's been sufficient for them.
Okay, great. Thank you very much.
Kind of keeps it simple.
Great. So another question about billing. Do you accept Medicaid as the payer source?
Yes.
Indeed.
Yes, great. Wonderful.
The only restrictions we have on billing is that we're a county hospital, so we obviously have a charity care program.
Sure.
So if the only exception to we treat our patients as if they're in our own clinic is that we cannot, under our Board of Trustees agreement, offer that charity care program to anybody who isn't residing in Laramie County. So patients that come to the clinic can access charity care through our county hospital process. But if telehealth patients that live in a different county can't access that charity care because we're not allowed to provide it outside county.
Right.
Other than that, we support patients exactly as if they're here. So yes, we take Medicaid, Medicare, and anything else.
Wonderful. And then one other question, and this goes back to the fact that you treat your patients as if they're there. How do you handle prescriptions or medications for patients in the remote locations?
Good question.
Yeah, that's a good question. So because of our electronic medical record, we are able to, the doctor puts in the prescriptions and it can go to their pharmacy. So that's all done through our system. If it is a controlled substance, we need to mail a hard copy, then we will mail that to the pharmacy.
Perfect. Perfect.
Yep.
But in today's world with e-scripts, it's made it a lot easier to manage.
It has made
Yes,
it a lot
it's
easier.
very easy. So that just goes out, the physician's talking to the patient, they're able to put that in, and it's already going to the pharmacy.
Yeah, it works very well.
Wonderful. That's really helpful. So we have a couple more minutes. Want to make sure we go out to the community to see if there are any additional questions. I want to thank you personally from the Wyoming Telehealth Network. We're so excited. We talk to Kevin a lot, and as he said, we hear a lot of great things. But it's wonderful to have you guys on the call and really giving us some pointers to say, this is how sites can really do this, right? So let's start
Yes.
ways in which we can do telehealth. If individuals are interested in telehealth sites or licenses or the technology, our telehealth network, which also includes key collaboration with Kevin and CRMC, go ahead and go to our website. I'm going to pull that up really quick because there were a couple of questions additionally about billing. And we spent some, quality time at the beginning of these really talking about what the services and supports for delivering telehealth service look like. And then we spent 2 sessions about how to code and bill for telehealth.
Excellent.
Good.
So on our website, you'll go to the University of Wyoming and just type in Wyoming Telehealth Network. It'll pop up here on the left-hand, this is called an index, right, Kyle? You'll see that there are webinars, and you'll be able to pull up the past recording. You can click on it to view the presentation that was provided, which may be helpful, but you can also click on the actual recorded webinar, which is what we'll be doing this webinar as well. Taking the recording, taking the handouts, posting it on our websites, hopefully within the next 2 weeks, so that individuals can get online and access the information. So hopefully we'll be building this as a really good repository for people to come learn, access information, and so any other questions?
One other little plug, Canyon. We're actually demonstrating some good interoperability today because we're doing this video conferencing using the Polycom Bridge network from Cheyenne Regional and joining you with the Zoom network from UW, and it's pretty seamless and high quality.
It's been great.
The platforms of telemedicine and telehealth now should not be getting in the way of providing the services.
Absolutely. And if that's what your clinic or you're currently struggling with is even just the technology, go ahead and send us an email. Go to our website. You can email us at, I think it's ytelehealth@uwyo.edu. I'll have Kyle post that in the chat bar, but you guys can go ahead and email us, and we'll sure help you with some of the technology pieces. And depending on what you have, we'll tap into either the expertise of Kevin and Randy or our expertise of our technology support here. Charla, I see that you've joined. Is there anything else you'd like to mention before we shut the call down today?
Excuse me. No, I don't think so. I think this was a great presentation. Thank you, everyone over at CRMC. And
Welcome.
just to emphasize that these licenses are of no charge. Technical assistance is of no charge. So anybody that's interested in pursuing providing behavioral health services via telehealth, as Canyon said, please go to the website. Thank you all for participating today.
Thank you for inviting us.
Thank you.
Thank you.
Perfect. So
Is that
just
it?
plug, we have another webinar coming up next month. So as we said, these are monthly webinars on March 29th, same time, and it'll be about how public health nursing can help facilitate telehealth for your practice. So I see a couple of public health nursing faces on the call, and we're learning, hopefully, Lindsay will be on the call from the state, and Cindy, hopefully you'll be back as well, to learn a little bit about some really exciting ideas about public health nursing being involved in increasing telehealth across our state. So I'm really excited about those additional conversations as well. And once again, thank you to CRMC for all of you do for patients across Wyoming and for talking to us today.
You're welcome.
Thank you, guys. See ya.
Thank you.